my thinking is, wherever I find myself in this country, I must be able to access a certain kind of healthcare. You understand? But if it's whether it be first aid, whether it be emergency care, whatever it is, wherever I find myself, the fact that we cannot get that is a problem. What I just want to highlight is just a broadening of the conversation. You spoke about. I don't want us to reduce the no bed syndrome to actual beds. And in the second part of your monologue, you spoke about it's a system. The no bed syndrome is a phrase that represents a broken system. When Ridge Hospital was expanded from 200 beds to 400 and something beds, it did not take away no bed syndrome. They had added beds. The arrival of UGMC has not taken away no bed syndrome. You understand? So, like you're saying, we can add a million
1 million beds.
We can add a million beds. There will still be no bed syndrome. That is the point I'm trying to make.
It's a systemized
the no bed
and
syndrome
for people's
as
lives.
a phrase. It's something that has been used to describe the absence of or the breakdown of an entire system. And that is why where I stand very strong now is with your call for more to be done. I don't want to go to the encore because you've touched all those things. I don't want to be repeating what you've said. So in expanding the conversation, I am saying, look, we need the people who run health in this country to not reduce their tasks to dealing with strikes, to performative gestures of, oh, I've seen this, then I go there, then I go and talk about it. The problems that this system needs to be able to wake up and live. Look, I'll read something to you. In 2023, the National Harmonized Health Facility Assessment was done. Bernard, I'll run you through some numbers. You'll understand perhaps where I'm going with this. Now, this checks every level of the health system below the tertiary hospital. That's district, regional, polyclinic, health centers, and CHIPS compounds. Only 32% of the facilities surveyed had staff who had received any training in emergency services in the preceding 2 years. Only 3 in 10 facilities have a strategy to meet staffing needs during an emergency. And I'm focusing on emergency because emergency care is what we are talking about here. Among the workforce that has the training, all of them are leaving. You alluded to that, right? We are losing the ones who are actually specialized in emergency care. They are the ones who are traveling. We are the ones we are also offloading to other Caribbean countries. The UK employs more Ghanaian nurses than Ghana does. Now, we talk about the tools. Only 4% of facilities offering emergency services have all the essential equipment for airway intervention, which is one of the most fundamental acts in emergency medicine. Only 2% have all the essential equipment for circulation intervention. Safe blood transfusion is available at just 15% of emergency facilities nationwide. Not a single one of the 1,487 facilities surveyed had all the assessed cardiac intervention equipment and medicines available on the day of the survey. Not one, Aloski. Not one. Less than 55% of hospitals and polyclinics have any cardiac intervention capability at all. DFIPs, without which cardiac arrest is effectively untreatable, were present in only 69% of regional hospitals, 43% of district hospitals, and 35% of other general hospitals. Adrenaline and aspirin, 2 of the most basic emergency medicines, were found in just 33 and 30% of emergency facilities, respectively. Only 15% of facilities had 24-hour rapid access to emergency transport for referral out. And only 4% had round-the-clock radiological services. Think about it.
So the things you've listed, some are facilities, like some are equipment and some are training.
No, I'm
so
saying,
human resource and also.
No, I'm just saying something. So if you put everything together, if all the hospitals, the districts, and we are looking at those pre-tertiary, have these things, you do not have the sway of traffic towards Kolebu, Ridge, 37 that you normally have, or UGMC. We will not be airlifting a minister from his region to Accra for what was not even an emergency. Because the basic required, there's a regional hospital there, is there not?
There's supposed to be.
Why was he not treated at the regional hospital?
You should ask those who brought him.
Exactly my point. I'm saying, so it's not that the things are not there. So he adds to the traffic that is coming to Accra, to Kolebu, to G, Konfanochi, or to the other Tamale Regional. So in the end, you have so many cases building up towards just 4 or 5 facilities which are already understaffed, ill-equipped, and undermanned. That is the no-bed syndrome.
Understaffed, ill-equipped, and undermanned.
Whoa. That is the no-bed syndrome, the way I see it. And to fix this no-bed syndrome, which is why I say, and my brother Nana Kofi makes a very interesting analogy. He says to equate this to just furniture, beds, it's like to equate farming to an abscess of plates. You understand? So we need the people who matter in the sector to improve these percentages. These percentages improve. The percentage of the no beds also what? Improve. Then we can do better. But that doesn't take away the most important call that you have made today. They need to respect life. If somebody shows up, whether you have to treat the person on a chair, on the floor, otherwise they will not be treating soldiers in the jungle, because they will tell you we need to lift the soldier from the jungle to Kolebu or somewhere. But at least some semblance of first aid or emergency care is provided to stabilize the human being before the person is what? Sent to a place. And that is, I guess, what we are all asking for. That when that ambulance shows up, when that taxi shows up, let a doctor, a nurse, or somebody who at least has a bit of training, if the emergency care specialist is not there, at least somebody who can help. Don't say we will not receive the human being because of all the numbers I just outlined. I think that is the most important call. Treat the person, give the person a chance. That's all a human being is looking for. A chance. If Mr. Emisa, in the 3 hours or so that he was being moved around, had been given that chance, perhaps Mr. Emisa would be alive today. You understand? If a doctor had simply even just paid attention, or some other person with some semblance of emergency care training, not necessarily a doctor, had said, let me just take a look at this gentleman. Perhaps he could have said, he needs A, B, C, let's give him that. And that would keep him alive. So I do share your thoughts.